Okay, here's a special test for the hip lab. The first one is the Thomas test for a hip flexion contracture. You have the person lie back towards the edge of the table here, pull both knees to their chest, and then hold one knee to their chest while they lower the other one to the table. The leg that's lowering should approximate the table. If it's not, if it's hanging here, that's a positive Thomas test for a hip flexion contracture. This is not to be confused with the Thompson test, which was the test for the gastroc-soleus tear, the Achilles tendon tear. Okay, so this is the Thomas test. The next one is the Ober test. You have the person lie on their side, and you have them bend their bottom leg and then extend their top leg, and your job is to keep the hip in extension. So the tendency, if they have a tight TFL, will be for their knee to flex, or their hip to flex as their knee approximates the table. You hold them here, bend their knee, and then have them drop their top knee towards the table. If it approximates the table, that is a negative test. If you have someone tell someone to drop their knee and their knee doesn't drop, that is a positive Ober test for TFL tightness. Okay, next one is the Faber test. In fact, I'm going to show you these three tests in supine that you can do quickly. It's going to be Faber, the 90-90 hamstring test, and the piriformis stretch test. Okay, so the first test is the 90-90 hamstring test. You flex the patient's hip to 90, and then you have them actively extend their knee while you maintain this 90 degrees of hip flexion. Your measurement is going to be how much knee extension they have, right? -15 to 0 degrees is normal. I'm going to do this on the other side so you can see. So bend here.
Really?
Then straighten the knee up, and the goniometer gets lined up with the stationary arm here, lined up in the mid-femur, the axis at the knee joint, and then the movable arm at the lateral malleolus. So this measurement here is -12. Okay, -15 to 0 is normal. From that point, you can do a piriformis test. I'm going to do this over here so you can see. But you will bend the knee and put it on the other side of their opposite knee, and then you're going to push their knee in. Now notice if I push her knee in to internally rotate the hip, there's a point where the pelvis starts to come up off the table. Right? Your job is to take that measurement right before that pelvis moves off the table. I always ask the patient, do you get a pinch in the groin or a pull in the butt cheek? Pinch in the groin means their hip is not sitting in proper alignment, and there's some corrections to be done. But you can measure this with the goniometer. Can you swing the camera right around here? And you place the goniometer so it's level with the ASIS. So here, this round part is going to be on the ASIS, which means this you're going to make parallel. You don't want to set it like that. It'll change your measurement. So line this up so it's parallel with the ASIS, and then the movable arm, measurement arm, goes towards the mid-axis, or mid part of the femur towards the knee. Okay, a normal measurement here is 40 to 45 degrees. This measurement is about 35. Okay, so that's piriformis, and then here's the Faber test. Cross the leg, let the knee drop. A normal Faber would mean that the tibia is parallel to the table. Parallel, if it's up this way, that would be a limited amount of range of motion for this test. And then a positive test would be pain in the groin, which would signal a hip problem, or pain in the lower back, which would signal an SI joint problem. Stretching here would be normal or a negative test, okay? So we can run through those really quickly. Again, here's how quickly it can be done. Here's the 90-90 hamstring test. Take that measurement here, then take the foot, put it to the other side of the opposite knee, internally rotate the hip till the pelvis starts to rise up. Take this measurement here for the piriformis, and then keep that foot there and let the knee drop this way, and here's the Faber test. Okay? All right. The next one is compression, decompression, and scouring. So what you want to do is, this is a test for osteoarthritis or any other joint surface pathology. So you just bend the knee and the hips to 90 degrees, knee is bent more than that, and I just put pressure through the long axis of the femur, and I just push, right? So if this recreates, this is a compression test, if this recreates the pain, reproduces the pain, that's a positive compression test. Okay, I can do this and just distract the hip by pulling. You can see how as I pull through the ankle, if I do this slowly, I'm pulling at the ankle, then I'm pulling at the knee, then my pull goes to the hip. If I pull this way and it causes pain, that would be a positive distraction test. In the case of joint arthritis, it would alleviate the pain. So usually someone with arthritis has a positive compression test and a negative distraction test. Okay. The other one that goes with arthritis to diagnose arthritis is the scouring or quadrant test. This is very similar to the motion you did with the McMurray's test of the knee. So here, again, hip flex to 90 degrees, you're putting pressure through the long axis of the femur, and then you are scouring the hip. So you're basically moving the hip in a teardrop shaped fashion while you're maintaining compression through the femur. A positive test is pain in the hip joint when you do this. That's the scouring test. And then the last test is, I think this is the last one we have. Yep, it's the sign of the buttock. The sign of the buttock. This is kind of interesting. And that if you move the hip into flexion when the knee is an extension, you will measure maybe a limitation in hip flexion. What then you do is you bend the knee and see if you get more hip flexion. If you do, that limitation's from hamstring tightness. If you do not get any more hip flexion, if I lift the leg straight up and let's say the hip flexion is limited to about there, about 70 degrees of flexion, and then I bend the knee and I still don't get any more, then that is a capsular restriction to hip flexion. So it's just a simple test to differentiate between soft tissue and capsular restriction to hip flexion. And that's the special test for the hip. I'm going to do a quick palpation of some key structures affecting the hip joint or around the hip joint. First one we're going to go from proximal to distal here. Starting here with the psoas major muscle belly. So you're going to find the belly button and lightly run your fingers lateral. You'll feel the roundness of the rectus abdominis. When you get over the roundness, then you are going to gently work your way in towards the spine. You are actually palpating psoas major muscle belly through the intestines. Okay, so that's psoas major muscle belly. If you find the ASIS is very easy to feel. You place your palms over and you'll feel the bony prominence. Find the ASIS and you go an inch in and an inch down. This is the conjoined tendon for iliopsoas. It's also a trigger point that we will treat with counterstrain. Okay, so an inch in and an inch down is the iliopsoas tendon, differentiated from psoas major muscle belly up here. All right. The pubic symphysis can sometimes be out of line, and we'll be learning some corrections for those. The way you palpate the pubic symphysis is take the heel of your hand, starting in the abdominal region, and work your way down. Okay, when your heel of the hand touches the top of the pubic symphysis, you can palpate the pubic tubercles, which are just on top. You can feel them on yourself by palpating just on top of your pubic bone. We will be assessing if one is higher than the other when we get to checking the pelvis. All right, if you find the ASIS and you move a little bit inferior, you will feel the less prominent AIIS. The AIIS is the position of, is the origin for the rectus femoris. The origin for rectus femoris, and that is sometimes tender as well. Another thing to check when the person is supine is to check if their pelvis is level. So if I place my hands on the ASIS, I want to see if the pelvis is sitting level or if it's rotated left or right. Probably the most common orientation we see is a left rotated pelvis, okay, which would look like your hands were like this. Okay, so go ahead and lie on your side. On the side here, from the greater, you want to palpate the greater trochanter. So if you take the heel of your hand and kind of run it down the leg, you'll feel the prominence of the greater trochanter. The very top portion of the greater trochanter is where the gluteus medius tendon inserts. So tenderness on the superior aspect of the greater trochanter is glute med tendon. Tenderness posteriorly is where the greater trochanter bursa resides. And so if someone has bursitis, they will typically have pain posterior aspect of the greater trochanter or directly on top. Okay, from here, if you look at greater trochanter and PSIS, PSIS is easy to find here, as if you have a difficulty finding it, follow the iliac crest back so you feel a roundness here. It's also lined very closely with the dimples on the back that you can see on a lot of people. But if you find greater trochanter and PSIS and find the middle point, that's where piriformis is. Piriformis is here, and then if you look superiorly just below the roundness at the top of the iliac crest, here's the trigger point for posterior gluteus medius. So it's not uncommon for me to ask patients what's more tender, A or B. A trigger point in the piriformis tends to show up in an overpronator. Posterior glute med trigger point tends to show up in oversipitator. Okay, lie on your stomach. So prone, you can palpate several things. So palpating here, the ischial tuberosity, take the heels of your hand, find the point of the ischial tuberosity, and you want to put your thumb on the lowest point, the most inferior point, and then point your fingers towards the sacrum. Your fingers are now in the orientation of the sacrotuberous ligament. So from here I can run my thumb transversely across the sacrotuberous ligament. It should feel like the web space of your hand when your thumb's extended. That's how taut it should be. If it is not taut, it may signal an upslip of the innominate, which is fixable. Okay, the other thing I'm going to palpate prone here is find the PSIS. Can you see that from over there? So find the PSIS here. You can feel the roundness of the PSIS if you simply run your fingers or your palms over the top of the sacral area. From the PSIS, if you're underneath them, this is the best way to measure the height of those, move your thumbs inferior and medial and keep your thumbs flat. You can detect if there's a deep side in the first sacral sulcus. We'll be talking more about this next week when we look at the sacrum, but I wanted you to be able to palpate these landmarks, okay? Another note, these ischial tuberosities, these are the points of attachment of the hamstring muscles. And so if somebody has a high hamstring tendonitis, you'll palpate some tenderness in this area. So the treatment techniques for the hip, the first ones are the two major mobilizations. I want you to know the first one is a lateral distraction of the hip and then a posterior distraction of the hip. These are the two most commonly limited accessory gliding motions. So take a belt, place it here on the proximal thigh, and then place your hand on the in between the patient and that belt. The belt is around my waist, and then I'm gonna stabilize her knee here with my forearm. Notice if I don't stabilize when I pull, she'll just go into external rotation. So if I stabilize here and then I lean back, I can get a distraction of the hip. And just like any other distraction, you want to oscillate about 1 a second. 1, 1,000, 2, 1,000, 3, 1,000, just like that. After you do 6 to 10 repetitions of this hip distraction, you can unbelt. I usually then have the patient extend their knee and I place my knee under their knee so I can use my leg pulling this way to do a distraction of the hip while I do a posterior glide. This posterior glide will help restore internal rotation and flexion. Okay, so just like that. Posterior glide of the hip while I'm doing a distraction with my leg. Those are the mobilizations. Counter strains, the first one is for the iliopsoas. This treats the conjoined tendon tender point. So find the ASIS, move an inch in and an inch down, and the tender point will be here. You can compare it to the other side. Okay, whichever one's more tender, you grab that leg. So I'm going to assume it's her left side. I get up on the table here, and I have her cross her ankles. So she crosses her ankles. I prop her feet up with my leg, and then I have her separate her knees. So externally rotate her hips. So the hips have to be flexed past 90, and the hips externally rotated. Can you open it? Just like that? Perfect. In a relaxed position, and then I reach down here and palpate to make sure that tender point is gone. So you can see me rechecking the tender point here. If it's 70% gone or more, I will maintain this position for 90 seconds. The biggest mistake students make is not enough hip flexion and not enough hip external rotation. Again, the involved leg crosses on top. Okay, that's iliopsoas. Okay, this is going to be the counter strain position for piriformis and quadratus lumborum. They're very similar. So find the piriformis tender point. Here's the PSIS, greater trochanter, spot right in the middle. This is usually where the tender point is. If it's tender, I'm going to move her into this position of shortening. So hip flexion past 90 degrees. Notice how you take her leg off the table and immediately put it on my legs, both my legs. And scoot towards me a little bit. And then I want to get internal rotation of the hip because the piriformis is an internal rotator when the hips flex past 90. Internal rotation, repalpate the trigger point. If it's better, this is the position that you hold. This is piriformis counter strain. Now watch the difference for quadratus lumborum. The tender point is up a little higher. You find the roundness of the paraspinals and then push in. And look at what I do to this position. I will actually raise my stool a little bit. raise my stool a little bit to get a little more external rotation and abduction of the hip. This shuts down the quadratus lumborum. So very similar positions. Quadratus lumborum is with the knee up here. Piriformis is with the knee down. And you palpate the trigger points accordingly. Okay. Stretching techniques you need to know. The first one is the quadricep muscle belly. And so what you do here is, person's prone, make sure the knee's in line with the hip. A lot of times if someone has a tight quad, they're lying with their hip in a little bit of abduction, and it will change the stretch. So move the hip to neutral, and then flex the knee. This one's pretty simple and straightforward. Right, go ahead and lie on your back. To stretch the hamstrings, you want to stretch starting in this 90-90 position. So you don't want to stretch a muscle over two joints at the same time. So flex the hip and then extend the knee, right? If it's possible, you can get up on the table and prop the leg up. And this is the position of stretch here. Now you can have them roll their foot in. This targets the lateral hamstring, and then you can have them roll their foot out. This targets the medial hamstring. Okay. And then the last one is the piriformis. The piriformis, many of you have known this figure 4 stretch, so this is exactly how this stretch is done. Supine figure 4, I call it. This is external rotation of the hip with hip flex past 90. That's the piriformis, differentiating it from the other external rotators of the hip, like glute max and the other deep 5. Except the piriformis, pushing the knee to the shoulder, is the other hip external rotators. Okay, piriformis is differentiated by the other position. Okay, all right, here's the muscle spindle massages that can be used in the gym to help inhibit and facilitate muscles. The first one we're gonna do is gluteus medius. Sometimes you wanna inhibit it if it's tight, right? So to inhibit, you're on the lateral portion of the hip from the top of the iliac crest and greater trochanter pulling in. So I'm just alternating my hand position to do gluteus medius inhibition. If you wanted to facilitate gluteus medius, you go from the middle of the muscle belly and you pull out, okay? Piriformis runs almost in a straight line from the greater trochanter to the sacrum here. So to inhibit, I will pull my fingers in. There's very few times you want to facilitate a piriformis. So we would oftentimes inhibit piriformis, and then if you can picture glute max running this way, here's my facilitation of the gluteus maximus. Right? So inhibit piriformis, it's more horizontal, and then facilitate glute max. And that's it.